Good morning, everyone, or good afternoon, wherever you are. So Mendy and I wanted to first just talk a little bit about the Caring for Child Survivors initiative. This is an initiative that was started really now about a year ago. It's a joint initiative with the International Rescue Committee and UNICEF, and it came out of the reality that many of the staff working in gender-based violence in the field, in humanitarian aid settings, including emergency settings, we're really seeing quite a few children coming forward with the experience of gender-based violence, and in particular sexual abuse. And our staff in the field were really were communicating with us that they felt not equipped to respond to these kinds of cases. A lot of the guidance that exists in gender-based violence is guidance that's geared towards adult survivors of sexual violence. And at the same time, we realized that those working in the child protection sector who had, of course, a lot of experience with working with children and on children's issues, really weren't familiar with some of the basic guiding principles, some of the basic approaches that the GBV sector uses. And in addition, and this might be specific for IRC, we were also finding that child protection agencies and gender-based violence agencies in the field really weren't sure how to coordinate with one another. So, if a child case came forward and the child had experienced sexual abuse, how were they meant to coordinate on that case together? Kind of who took the lead if the presenting problem was sexual abuse, and then how would they work across agencies to support the child's needs? So in September of 2010, we really launched this initiative again with UNICEF as a key technical partner, and then also supported by, financially supported as well by UNICEF, by the Gates Foundation, the Bill and Melinda Gates Foundation. I'll talk about that separately in just a bit. It's related to a mental health intervention. And then the U.S. State Department. And the overall goal, as you'll see if folks can see the slide up right now, is for humanitarian field staff to have the technical expertise to deliver child-friendly, age-appropriate case management, psychosocial, mental health, and clinical care, that's health care, interventions to children and families affected by sexual abuse. So there's a lot there, right? A couple of things that I want to point out is that the technical resources that we've been working to develop really have focused on sexual violence, sexual abuse as the primary gender-based violence experience for children. So just to highlight that. I think we can move to the next slide. Okay, and you might need to click it a few times. Okay, great. So there's really two overarching objectives with this initiative. The first is, of course, to develop tools and resources to help improve core services. And core services, what I mean by that, really is case management and psychosocial interventions. And, of course, health care. So those are really what we're thinking about in terms of the core services that children need to receive. In addition to that, the IRC is also working with Johns Hopkins University on an impact evaluation, very exciting evaluation actually, that's primarily funded through the Bill and Melinda Gates Foundation, where we're looking at what mental health intervention for children who are suffering from traumatic stress as a result of sexual abuse, and now we're actually broadening it out to other forms of violence and abuse. We're piloting a mental health intervention in Ethiopia and Thailand and gathering some evidence around it to see whether or not it's effective or not, to see if we can actually go above and beyond basic psychosocial care and case management to actually having an evidence-based mental health intervention that we can provide to children who've experienced trauma and abuse. That impact evaluation is just really getting going in Thailand now, and we're just in the beginning stages in Ethiopia. And there's a lot to it. I won't go into it, but in effect, the most important thing for you all to know is that we won't know, of course, if this intervention is indeed effective until we go through the study. and we won't have results probably until the end of 2012 and going into 2013. I did want to highlight that, though. The second objective is to identify strategies for improving coordination among child protection and GBV providers in the field, and I would also add health providers as well, although you won't, their circle is not there right now, primarily because we see some of the greatest challenges in terms of coordination between GBV and child protection agencies. Mendy, did you want to add anything before I move on?
No, that's okay. Go ahead.
Okay. We'll go to the next slide, please. So I wanted to give you a bit of a background in terms of how this initiative had first come about, so that I can then we can then orient you to where we are now. Thomas, I think you can click the button a few more times. Okay. So, you know, what's happened since September of 2010? Well, in essence, we've been working very, very hard at developing technical guidance. Now, this is not; these are not training materials as of yet. So I do want to highlight that. And Mendy and I will talk a little bit about a recent training we did using these materials in Uganda. And we also have another one that's coming up that I'm facilitating back in Uganda, March 5th to the 9th. But the first thing that we worked on was a literature review, a fairly comprehensive literature review, looking at what's the evidence for psychosocial care in case management and health interventions for child survivors of sexual abuse that we know exist. What are some of the practices that we see in the field and some of the evidence that's garnered in the field, and really mapping out, you know, the base, the literature and evidence base for the program model that we put forward and developed. So the literature review, I think, has been sent to the group. That's completed and published and available for anybody to reference. Based on the literature review, we came up with a program model, and I don't have that in front of me, but in essence, you know, our goal is that children heal and recover from sexual abuse. So if that is our ultimate goal, and from service delivery angles, what is it that we need to have happen? For case management, what is the case management that needs to happen? What are the core skills and knowledge, and really attitude as well, attitude competencies that we want to have caseworkers in the field having in order to provide effective and quality case management for child survivors of sexual abuse, and the same thing for healthcare providers. So the literature review really helped us to develop what the program model was. And then from there, you'll see in yellow are the CCS, the Caring for Child Survivors Implementation Guidelines. This is really the key tool for the field. The implementation guidelines are essentially the how-to of the program model. And we'll just go to the next page. Okay. Great, thank you. So you'll see on the right-hand side are the guidelines, the Caring for Child Survivors in Humanitarian Settings guidelines. And as I mentioned, this is the how-to. So this really walks the reader through step by step, what are the components, the knowledge, the attitude, and skill components that both child protection and gender-based violence field staff should have when they're providing care for child survivors. So it goes through the technical knowledge that service providers should have about child sexual abuse to inform and help them carry out the care and treatment. It goes through essential attitudes. What I found, and again, I'll talk in a minute about how all these resources came about, but one of the things that I found when I was piloting these tools in the field, because they have gone through field pilots, is that attitudes were really a major barrier for some service providers. Misunderstanding about sexual abuse, and at times even blaming children for the abuse that they had experienced, or really a difficulty in accepting that a child could be abused by someone the child knows, was really affecting how care and treatment was being delivered. So we do really highlight the importance of you know, of having the right attitudes, and then helping supervisors to walk through how would you evaluate your staff to ensure that they do have attitudes that are consistent with a person who's empathic and caring and able to provide care for child survivors. The guidelines go through skills for communication, so really just, the foundational skill set for how you would set up an interview, what kind of questions you would use to guide interviews, and then also some skills for engaging children who have a hard time speaking. So some nonverbal interventions are also included. And then the last several chapters really focus on case management. So it walks the reader through step by step by step. How do you provide case management to child survivors of sexual abuse? In addition, it provides pretty thorough guidance on how you handle informed consent according to a child's age and development stage, how you handle mandatory reporting. And many of us know in our settings that there might be, mandatory reporting laws and policies that exist, but that aren't necessarily safe for, to activate. So it talks about how to handle that. And it also talks about how to handle confidentiality issues in child cases. Because when we talk about children, we're, of course, looking at a large subset in terms of age and development stage. So how you'd handle informed consent with a 16-year-old and how you would handle informed consent and confidentiality with an 8-year-old is not going to be exactly the same. And then lastly, there's a chapter that goes through, I guess what we've now termed coined the term advanced case management. And that's really case management where additional psychosocial interventions are included. So psychoeducation, relaxation training, how to teach children coping skills and problem solving, teaching about body safety. So not just safety planning as part of the core case management response, but then also some additional tools for children to use to help keep their bodies safe in the future. Okay, I think we can move to the next slide. Oh, and there's also guidelines for monitoring care and treatment. Move forward. Okay, so the guidelines that I just walked you through are exactly what I mentioned. They're guidelines. They aren't yet training tools. However, as part of developing these guidelines, I was in the field doing 6-week pilots in 2 refugee camp settings, in Ethiopia and the Somali camps, and then also in Thailand. So during that time, I was, of course, taking the guidance and putting it into training. And then Mendy and I also just came out of a 5-day training in Uganda with child protection and GBV practitioners from the Horn. And we, definitely have, learned, we also learned a lot during that training. So this is actually a slide from the workshop that we just completed in Uganda. So I'll just walk people through what the workshop goal was. So the goal is to train service providers in the foundational technical knowledge and skills for caring for child survivors. Sorry, folks, I live near a fire station. Let that go. Okay. A key focus of the training was on building comprehensive knowledge about child sexual abuse and training on child-centered interviewing and engagement skills. The training will also introduce participants to child case management and psychosocial response approaches and best practices for survivors of sexual abuse. You can go to the next slide. So after the training, the objectives that we wanted participants to be able to meet was that they would be able to demonstrate technical knowledge in the area of child sexual abuse. So a key goal of these trainings is really to eradicate any misinformation that exists and also to help practitioners reflect on what is happening in the area of child sexual abuse in my setting. Of course, there's going to be technical knowledge and facts and information about the dynamics of sexual abuse, perpetrators, profile, some of the key, places where children may be more at risk for sexual abuse. So it's really also about helping them to reflect and begin to gather information and think about, well, what is it that I know? What happens, around the issue of children and disclosing? Who do they disclose to? How do our service providers come to find out about these cases? The second objective, and this is a really key one for me in particular, is that the training participants can demonstrate skill in communicating and interviewing child survivors. Case management and psychosocial care, the key tool that we have as practitioners is our mouth. We really need to know how to use our words and not just our words, of course, our body language, and have all sorts of tools in our toolbox to communicate and interview child survivors. So we focus quite a bit on that. And we'll talk a little bit about some of the methodologies we used. We really wanted the participants to walk away with an increased understanding of the key guiding principles and procedures in child case management. So, child protection has core guiding principles, and the gender-based violence community has core guiding principles. And what we've done as part of this initiative is to integrate those principles into one set so that you have safety and confidentiality, things that would cross over in both sectors. But, for example, in the GBV sector, we don't necessarily have a guiding principle that's around child participation or best interest of the child that's explicit in how we think about our work. And so we've really, integrated those guiding principles together, and that's a key learning point in the training. And in addition, the procedures that I've mentioned already, how to handle informed consent, how to manage confidentiality protocols, these are fundamental in terms of how people understand them and use them in their settings based on their environment, but then also according to the child's age and developmental stage, the caregivers where they fit in. The fourth objective was that the participants learned key psychosocial care interventions for child survivors. So this is a little bit different than the referrals that we often do to, for example, to child-friendly spaces or helping a child go back to school if they've been sexually abused and no longer are either able or feel comfortable to go back to school. These are direct psychosocial care interventions that the caseworker or the social worker would do directly with the child and his or her family member, and they're more geared towards increasing their understanding of sexual abuse and what happened and what the common reactions are, to really empower children and families to have information and know how to, for example, use relaxation training if there's high levels of anxiety, or to learn skills for coping and problem solving if issues come up, if behavior is impacted in some way as a result of the sexual abuse. And then lastly, we really wanted everyone who's coming to the training to develop action plans for taking the information back to their setting and thinking about how to integrate the Caring for Child Survivors tools and guidelines that we had introduced back into their setting. Go to the next slide. So none of these, I kind of put this together a little bit quickly, so I hope that we can have a more robust discussion, and Mendy will jump in as well. I mean, these training methodologies I don't think will be a surprise to anyone. First and foremost, I want to highlight that, training, two things. One, training on the issue of child sexual abuse is not an easy topic, and a lot of the topics that we train on are not easy, and this one in particular. And so creating a safe training environment is key, in addition to the fact that it's difficult content. And with the exception of the last training I've done, I don't think that I've gone through any training without having participants disclose directly to me their own experiences. So that's something as a trainer you have to be prepared for. The second point I want to also make is that child protection and GBV staff don't often have a chance to come together and sit in the training and sometimes have different approaches or different understandings about how to, how to respond to children or respond to cases of child sexual abuse. So I think another, really important element in terms of creating a space and a good environment in the training room is to really start to build up the connections and the cohesiveness and the understanding of child protection and GBV actors. Of course, using experiential and participatory techniques is key. So every step of the way, really trying to build, get people into the experience of the work. Training on children with adults, I found, is not easy to do because we're adults, and it's hard to role play being a child, for example. And so there's all sorts of little things that Mendy and I did, for example, in the very beginning when we're looking at the expectations, we have the participants draw a picture of a child, and they actually named the child, and around the child they wrote out, what is it that I want to learn this week? What is it that I want to have happen this week that's going to help me help this child? And so, just using a lot of small techniques constantly throughout the training that really get people back into this experience of what it might be like to be a child who's been sexually abused, and what's my responsibility as a service provider to create safety and comfort for that child first and foremost. We also had participants develop case studies as homework on the first night of the training, which I found to be, and Mendy can speak as well to this, to be quite useful. Rather than us coming up with case studies ourselves, it was great to have the participants come up with them, and then we use those case studies all throughout the training. So we use the case studies to deliberate on how they would have gotten informed consent, for example, from the child and or caregiver in their particular case. We use those case studies when they practice communication. So rather than have a child that they had been given to role play, they actually were focusing on the case that they had come up with. We focus a lot on in-training practice of skills. So for communication, the way that we structured this was we had 30 participants, so that's a lot, and it's hard to have people do role plays. Because you as a facilitator aren't able to observe. And so we broke people up into groups of 9, and each group went with one facilitator, and then we had small groups where they practiced role play. So it would be 2 people doing a role play, and then you've got 7 people watching and then evaluating them. And that seemed to work really well, and I think participants were able to take the role play more seriously because obviously they had people watching and evaluating. And in the role play, we would have them role play the first 5 minutes with the child survivor, or how to explain a referral, for example, or having them think about how they're going to obtain, informed consent, either for continuing with an interview or for referrals. I'm going to stop there because I think I've been talking for a while. Mendy, do you want to jump in and share your thoughts from the training?
Sure, thanks. Well, I think you covered everything really, but I think that the key to the training was really making it as experience-based as possible. So really helping people get into that mindset of working with the survivor and really practicing the skills. I think we do a lot of training where we throw a lot of information at people, but we don't really give them a decent portion of the training where they just get to focus on applying those new skills. So I think that was really the essential part of this kind of training, so that people feel more empowered and ready to really communicate and engage with children on the spot after they leave the training. So otherwise, I don't think this kind of training will be all that useful if it's really just if it remains at the theoretical basis and doesn't really get kind of into the nitty-gritty of dealing with what are really complicated cases. So I'll stop there.
And Joanna, we might want to open it up, and I just want to. We'll go through the next steps and access to resources as well before we hang up. But one thing to note is that what we do have in terms of product, so to speak, right now, is we are going to have these guidelines and basically the last step for us is going through a design process, so that's why they're not publishable at this moment. But they will be within the next month or so. But we are going to need to work on a training curriculum to accompany these guidelines. It's a lot of information in the guidelines, and so one of the most important things as a facilitator to think about is who's your audience and what content are you going to choose to focus on for those 5 days. You can only do so much in a 5-day training. We could have spent the entire training just on case management or just on psychosocial care. Or even just on core concepts. So, I just wanted to highlight that, in terms of something that's an outstanding step for us to think about within IRC and UNICEF, how we're going to accompany this with training guidelines. But then also, for those on the call, once they have these guidelines and want to use the content from them, they'll have it there, but the key question will be, what am I teaching and how am I going to teach it? So we want to open it up to questions
on that.
Oh,
Abby,
yeah.
I mean, we had a mix of people that were really primarily frontline service providers, and then we had UNICEF staff, and we had some government counterparts from the 3 countries. And it was, really important for us to bring everyone kind of together and have them be on the same page, have the UNICEF staff sort of really understand the complexities of dealing with these challenging issues, such as getting informed consent when you're dealing with a child survivor, working with their caregivers, and what that means. And then that the UNICEF staff really knew what their role and responsibility was within that framework, that they're not necessarily, even though we're having them do some practice around using these new skills and using the new knowledge, that they're not going to be on the front line, but they need to have that understanding of how things should be handled, based on the guiding principles, based on the guidelines, so that they kind of can help their implementing partners and their government counterparts in the future. So it really, I think it worked in this situation to have kind of different layers of people in the same room, but we had to work with them to make sure that they really understood what their role and responsibility was within that sort of framework. So shall we go to questions?
Hello, this is Martini from Zimbabwe office, UNICEF. I have just one question for the training. Can you hear me?
Yes, go ahead.
Yep.
Thank you, Mendy, for the great news and it's a great training. My question is really, the training is really great, and we did the Care for Survivor training last year in Zimbabwe, but it's really difficult part is like how to really monitor the impact, like the changes of services. Everybody loves training, and they go back, and it's really difficult to see how actually the change is. So I wonder if your initiative is also thinking like monitor the quality of services or something to develop indicators or something to actually measure how the training affects to the actual service provision.
Actually, it's Joanna, could I add a little element to that? I'm wondering if you have a pre-workshop assessment tool as well, as well as the post.
Sure, I can speak a little bit to that, and then Mendy, if you want to add your thoughts as well in terms of how we handled it with the last training. 2 things I want to share. I mean, first of all, in terms of the standard way that we measure in training participants' uptake of knowledge and skill, we do of course have a pre and a post training questionnaire that we administer, and then are directly, using other knowledge validation techniques throughout the training. So quizzes, doing the role plays and things like that, so we can directly observe how the participants are uptaking knowledge and skills in vivo during the training. The question about, evaluating post-training is a fantastic question, and, and one of the things that the guidelines include are, and this is I guess a guideline, it's more about the guidelines and perhaps less about the training, although it's certainly related. The guidelines have several monitoring and evaluation tools. So for example, after a person goes through a training, and let's say that you're in the field and you're teaching staff and you've done a 5-day caring for child survivors training, we actually have staff competency tools that can be used to assess individually with staff members. Now this would take time, of course, but to assess more than a pre and post training questionnaire, how well they understood the knowledge concepts and how well they understand communication and case management skills. Now the way that these staff assessments are talked about in the guidelines is that these are really, you know, tools that supervisors and program managers should be using to really ensure that they do have staff that are ready to treat children. We know that it requires special skills to work with children, so how are we monitoring that at the programmatic level? So teaching the training participants these staff monitoring skills, you know, needs to be a key focus of the training. And we didn't have, I'll be honest, I feel like we didn't have as much time as we needed to really walk through those with the participants we just had. And, you know, and in addition, there are tools for program evaluation. So, for example, once a child and family has gone through case management services, there will be tools for them to evaluate the effectiveness of the services they received, and then also a case management checklist that supervisors can use with staff. So I think in terms of really getting these materials into, or getting this training more embedded and changed in practice at the field level, the key for me is going to be having them use these competency assessment tools and checklists to monitor their program and their program's quality of care and treatment. Mendy?
Yeah, the only thing, just a couple things I would add are that we have people working in the 3 country offices that were trained as GBV specialists, and so they're going to go back and continue working with the people that we trained. So they're going to use those, you know, kind of support them in using some of these tools that Abby was talking about in terms of measuring sort of staff attitudes, measuring their capacity around communicating with survivors and things like that, and in terms of their service provision, and also within the next 5 months at this point, we're going to go back to each of the participants with a follow-up kind of questionnaire to sort of assess how they've integrated the new knowledge and skills into their practice or into their agency service provision, what challenges that they're facing with using the guidelines, using some of the new knowledge and tools that they've learned about, and then kind of what are those trouble areas that we can maybe work with them on them in the future. Because one of the things we do in our trainings all over is we focus on the pre-post, but we don't really sort of look back after several months to see if they really are using the new knowledge and skills. So that's what we're trying to do this round.
Other questions?
Yeah, it's Ilva here. I have a question. Thank you for that presentation. It's very interesting and links into some of the work that we're looking at as well. And therefore, I was wondering, in terms of, you say it's what focus it has on boys in particular as survivors of sexual violence and abuse.
Great question. Boys are very much included in the guidelines. So the guidance that is mapped out is both for boy and girl survivors, and then we have a section in the guidelines in particular that focuses on, what we know, at least what we know more at a global level versus, context and local context level of boys' experience of sexual violence. And really, and definitely, helping practitioners to accept and understand that boys can be sexually abused, and then go through the myths around that. There's a lot of myths around homosexuality, sexual abuse causing homosexuality, issues with, male masculinity and victimization, particularly for adolescent boys. And so these things are certainly addressed in the guidelines and needs to be brought out explicitly in the training room. And, just to note that the case studies that everyone came up with, every single case study was a girl. And so I actually changed a couple of them to be boys. And, you know, and that was, you know, that was, and people in the room certainly will say boys experience sexual abuse as well. You know, so it wasn't as the participants didn't recognize that boys were victims of sexual abuse in addition to girls, but, you know, the tendency is to always go with case studies and whatnot that have girls, because of course we know girls are experiencing sexual abuse at higher rates oftentimes than boys are. The reality is, though, just to note that we don't, you know, one of the things that needs to happen in these trainings is, again, the reflection piece for folks in the room to think about what is it that I do know and that I don't know, particularly around knowledge. I've mapped out what the knowledge areas are in the guidelines. So there's 10 knowledge areas that staff need to have competency around. For example, what is the definition of sexual abuse? How much does it happen? What are the common reactions that children face? What's the difference between boys and girls? But one of the things that's important is for them to also take another layer to that and think about, and what do I know about this in my setting? Because it's going to be different in each setting. And if I don't know anything about children's experiences of sexual violence, then what am I going to do to try and find information out and really understand this better so that we can be sure that we're, designing services and thinking about this issue in a way that's appropriate to the local context.
Yep. And just another question, in terms of the trainings that you have done and the pilot testing, has that been more in regular development settings, or has it been in emergency, natural, or conflict settings as well?
All the pilots were really in protracted refugee camp context. So the Thai-Burma border, and then also the Somali refugee camps in Ethiopia, and that's a very particular context. Yeah. The guidelines are meant for broader emergency refugee camp, post-conflict settings. Although the pilots did take place in refugee camps, and the recent training that we had was focused on the Horn because of the emergency that's happening there. So we actually had quite a cross section of folks who were from refugee camp settings, Dadaab, but also several staff who had come from Somalia, and then we also had staff who were working in Kenya, different parts of Kenya as well. And so one of the things that needs to also come out in the training is to think about these different contexts that we have in humanitarian aid settings, and the fact that your case management approach is going to be different in an emergency versus a more protracted refugee camp context or a post-conflict development context, which is in part why we separated kind of case management and advanced case management, because really case management as it stands is a service that can be delivered, I think across several different kinds of contexts. But providing providing ongoing psychosocial care to children in addition to coordinating their needs, that might not be possible if you see a child one time and you have one chance to understand what happened to them and to mobilize the crisis intervention they need. Any other questions? Can I ask a question? Are folks training about child sexual abuse currently?
I did a little bit in Haiti.
A little bit in Haiti? Do you want to share some of your experience?
Say that again?
Could you just share a little bit about your experience?
Well, it was entirely impromptu because I'm a child psychologist and child protection officer, and I had no background. I mean, I had a lot of background in GBV and child sexual abuse, but I had no background in doing it in an emergency setting. So I organized a women's committee centered around getting the word out to people that the ongoing GBV that was going on in the displacement camps needed to have some kind of protection committee. So we oriented it more around protection committees, keeping the camp safe, and then referring children as needed to these women who are victims themselves, not sexual abuse victims necessarily, but victims of the earthquake. And it was a very uplifting experience in that there was a lot of sharing going on. I just made sure that it was a safe space for them to do it in, as both as a male and as an outsider. And so I just gave them some basic guidelines on how to go with it. And it was difficult, but very moving.
Great, thank you. I think you raised an important issue that I also want to share, which is that in terms of the guidelines and what folks can expect from them, is that the guidelines that have been developed have been written for service providers who provide case management and psychosocial care already in the context of child protection or GBV. But there's a lot of other guidance or interventions that are needed, and in particular, as you were just referencing, thinking about the community and their role in child protection and how that whole process works, and really the readiness of the community and thinking through sensitive awareness raising on the issue of sexual violence in children, and how that needs to happen in addition to ensuring that there's good services, because we know children don't disclose violence very often, and so it does require that caregivers and other people in the community are also aware of these issues and know what to do if they're worried about a child or if they fear that something has happened to a child.
I'm surprised. It looks like you had Jessica Lenz on the line for a while there.
I'm not sure, but...
Well, I don't see the list.
Sounds like Jessica's there.
Jessica's done a lot in this area.
Jessica, share.
Yeah, I'm sorry. I got cut off, and so I'm coming in the middle of the question, and so all I heard really was about community-based responses and working with children of sexual violence. I don't know if that was the question or what you're getting at, Tony. I'm sorry, I really got cut off there.
No problem. That was one of the topics that we had just talked about. But if you'd like to add, we'd love to hear your thoughts on that or anything else that you have on the issue overall.
Just a bit, I guess, in terms of community-based stuff. I did some work up in northern Uganda, working specifically with girls who had experienced various forms of sexual violence, and found that although that they were very much connected to social workers, they didn't trust them, obviously because of some of the attitude and how they were treated. But they found that by forming together in their own groups and kind of creating, these girl groups or female kind of empowerment groups, that was a way that they were able to actually share their experiences and what they were going through, and it was a way for them to actually learn more coping skills and being able to actually reach out to others who had gone through similar things, or at least even if they didn't go through it, they were there to be able to help, as a friend or to be able to give them various support. So that just in terms of community-based kind of approach versus the actual social work, or the an individual in another network that they weren't so connected with. So that was maybe a little bit of sharing. I did have a kind of a quick question though, in terms of when you were doing the training. Just in general, we do a lot of this type of training, and obviously, a lot of people do come up and talk about their own experiences. And you mentioned that, and I'm just wondering how you handled that situation. What were the steps that you took as a facilitator to help that person, or to to deal with, if issues were coming up for participants themselves. Maybe you can talk a little bit about that for facilitators.
Sure, yeah. There's two types of disclosures that I've experienced. One is direct disclosure to me privately, which is the most common, and then also a public disclosure in the training room itself. And so I'll share how I handled both situations. In terms of the private direct disclosure, of course, as I'm a social worker, licensed clinical social worker, so, I was able to draw upon some of those skills and, of course, listening, validating, and really just, being a person that this individual, feels comfortable to share with. And in one situation, it was the first time this had ever been, shared publicly. And, of course, it was, we know many adult women and adult men disclose many, many years later once they feel safe enough to do so. So listened and, of course, validated. And then in different, with different people who disclosed, so a bit about how, asked about how they were going to think about getting support if that was something they wanted moving forward, in particular given the fact that they are service providers working with women, mostly who are survivors of violence, but then also children. And, just talking a bit about how that, working with survivors is affecting them. And so that was the kind of direct and private disclosure. In terms of the one that I found, the few times this has happened that I found to be a bit more challenging is when you're in the training room and someone stands up and then shares their story. And, I absolutely did not shut them down. And, monitored closely. The person was composed, articulate, was, had already, to some extent, dealt with and processed the abuse and wanted to share, how the healing process happened and some of the longer-term effects that this person was still dealing with. And so what I did is I allowed the person to finish their thought, absolutely, and then again in public to encourage and validate and really use healing statements that, you're so brave, thank you very much for sharing this story, and, offering some validation. And then, but then, slowly it's closing down that discussion. So I did not want that to then turn into a group discussion where there was a lot of Q&A back and forth with this person in the training room, because towards the end of the disclosure there was some emotion as well. So what I did is just, offered up the space and asked permission if people had questions on their own, would they be able to approach the, X person, and she said yes, that was fine. So I don't know if other training participants did end up following up. What I then did as a facilitator is later on, in the training, myself went to follow up with that person, having a sense that they might have regretted or felt worried about the fact they did disclose, to do some additional reassurance and additional validating that was, that was something that she felt compelled to do and was important and that was great and that I was proud of her for doing that. But I guess, just to say that, expect that, I think of training almost as an intervention myself. I mean, I expect that I have survivors of child sexual abuse in my training room, and that means every word I say and everything I do needs to be healing for participants in that training, because likely I'm on some meta level doing some sort of psychosocial intervention myself by constantly repeating that children are not to blame for this happening and explaining some of the common things and feelings and reactions that society has, and validating the experience for folks in the training room. And so just to say that, and to perhaps other people on the call have had this experience, but definitely to be prepared for disclosure. and think about how you'd handle disclosure at the group level and individually with you.
Abby, it's Joanna and Mendy. If I could jump in and ask, in your first day as you're framing your training, do you almost put this issue, perhaps not on the table, but weave it into your introductory framework? That many of us come to this work because we have either had some of these incidences, whether it's sexual violence or whether it's other forms of child abuse or whether it's various rights abuses, happen to us or to somebody who is near and dear, and that is what draws us to this, one element of what draws us to this work and what can give us strength in this work? Or do you find if you kind of weave it into that introductory framework that maybe you'd be perceived as looking like you're eliciting people to disclose and so on?
It's a good question. The way that Mendy, please jump in here. The way that I've handled it generally is to at the very beginning have a discussion, and this is actually part of the creating safety and the safety agreements in the room, but it's to talk about, more generally, is talking about child sexual abuse easy or hard? And we draw a line, like either on a flip chart or have a piece of masking tape on the floor. And people can come up and stand on that line or put a mark on the line, whether or not they can talking about child sexual abuse in their community, in their family, with friends. We can look at different scenarios, is easy or difficult. And of course, most people put difficult, and it's usually people in the training room from all different contexts. So it first allows us to acknowledge that this isn't easy content to discuss. And during that conversation, I'll talk about different reasons why it's not easy. And in some trainings I have directly said, bearing in mind that everybody in this room has their own experiences, basically life experiences that they bring, that they come to the training room with, and and that experience is really, really important, and how and knowing that we all have different backgrounds and different experiences, and we're talking about hard content. How are we going to work in this room to create safety for each other? So yes, the short answer is yes. Mendy?
Yeah, I think sorry, given that we're running out of time, maybe I think you've covered that really well, Abby. So if there's other questions before we end.
Yeah, perhaps we have time for one more question.
If there are no more questions, I can share just the next steps in terms of the resources. Should I move on?
Yeah, go ahead, Abby.
Okay. So I just wanted to let folks know that the final Caring for Child Survivors implementation guidelines, which is the key field tool that I spoke about, are going to be ready to distribute to the humanitarian aid community at the end of March, early April. So folks on this call should definitely be seeing, we're going to be, going through a whole launch process to get these guidelines out and into the hands of UN and NGO community members. In addition, and I know that this is a bit US-centric, but I'm also going to be hosting some quote-unquote Meet the Resources events in Washington, D.C. and New York for NGO and UN practitioners that are based here. And if we can find money, we can do them in other places. But basically to actually go in depth for 1 or 2 days on the guidelines and to really help folks think about how to bring this to life, either through training, large trainings, or through just their own programs. So SAVE or IRC or CARE, if you're operating GBV and child protection programs, how do you take this what is going to be a 200-page document and really break it down and use it so it's digestible for you and for your staff in the field. So expect that in the next 1 to 2 months. If you don't hear anything, then please, email me directly. My name is Abby Erikson, and my email is abigail.erikson@rescue.org. But you could Google me, or I'm sure we'll send out notes in this meeting with contact information. And you can also contact Mendy, who's connected, I think, more directly to this group, Mendy Marsh, of course, at UNICEF. And then one last note on the mental health impact evaluation that I had mentioned. We'll be carrying that out throughout the next year, and we will be hosting events and sharing information about the results of the impact evaluation and the effectiveness in treating children's mental health problems as related to violence and trauma. That likely will not be discussed publicly or any public events around that until early 2013. So that's all from my end. Thanks to everybody who's on the call. I know it's a short call, but we're really happy that you were participating.
Well, I think it's really up to us to thank both of you. So thank you, Mendy, and thank you, Abby, for your time and for your insights specifically into this initiative that you're developing, but also into kind of providing us with some examples of tools and ways to be thinking around our training. Especially, I mean, most of us are doing basic and intermediate level child protection and emergency training covering a variety of topics, GBV being one of them. And I think even some of the tools and ideas that you've brought forward would very easily integrate into those kinds of training as well. And I'm hoping that we can get you back later on in this series to kind of look at that module as it gets released. So thank you very much for your time.